Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. This is one of 6 episodes taken from a webinar on barriers and solutions to expanding PrEP uptake, featuring Dr. Timothy Wilkin. Dr. Wilkin is a scientific and medical consultant and a professor of medicine in the Division of Infectious Diseases at Weill Cornell Medicine in New York. In this episode, Dr. Wilkin discusses barriers to PrEP uptake for cisgender women. For the full online educational program, please visit the link in the show notes for this episode. Now let's get started and hear what Dr. Wilkin has to say about barriers to PrEP uptake for cisgender women.
So next, we're going to talk about PrEP uptake in cisgender women. It's good to think about what populations or which women are accessing PrEP services at your institution. So when we look at PrEP use in cisgender women in the US, daily FTC-TDF and long-acting cabotegravir have been effective in preventing HIV transmission when adherence is high. That's a big caveat. So for daily FTC-TDF, many studies of its efficacy in cisgender women have failed because adherence has been poor. In the studies where adherence was generally high for cisgender women, there seemed to be good efficacy. And then in long-acting cabotegravir, women did particularly well. And so those that were adherent to the cabotegravir had high degrees of protection against HIV. So when we look at trends in PrEP use among women in the US, the group most likely to use PrEP are those aged 25 to 34. And then again, regional differences with those in the Northeast being most likely to be prescribed PrEP per capita than other areas of the country. So some of the barriers to PrEP uptake in cisgender women, there's low awareness or lack of information, low perceived risk for HIV. So when you look at cisgender women in general in the US, there is a low risk for HIV infection. But in certain populations, that risk goes up. In certain communities, that risk goes up, geographic locations. So the concept of risk does need to be individualized in this setting. And then there are a number of competing priorities for cisgender women. The daily adherence of taking oral PrEP can be a challenge for many people, and as well as the perceived complexity of PrEP monitoring and follow-up. Many women have a preference for barrier protection against other STIs as well and unwanted pregnancy, which they view as the alternative to PrEP. And there can be concerns about adverse events, drug interactions, disclosure and stigma to their partners, families, friends, financial challenges, and then worried about the potential increase in risk behavior. And again, there can be distrust in the medical system. I don't know that we talked about it specifically, but the racial disparities for HIV incidence is quite high in the US. So the rate of HIV acquisition is like 20 times higher for Black cisgender women as compared to white cisgender women. And so part of those disparities is fueled by the distrust in the medical system among many communities. So again, another study in Atlanta tried to address getting cisgender women at risk to access PrEP. So they did an implementation study to improve HIV risk assessment, PrEP counseling in 4 safety net clinics in Atlanta. And so the providers and staff underwent PrEP education and training, and then 500 women underwent exit interviews following one of these family planning clinic visits. And they reported that only 19% had ever heard of PrEP before the visit. Over half of patients reported that their providers discussed how to prevent HIV, and most of those included PrEP as part of that discussion. 29% were deemed to be at risk for HIV by the provider. And of those, 2/3 said that their provider discussed PrEP. 29% were interested in PrEP. 18% received a referral for offsite PrEP. However, 76 would have been willing to take PrEP if offered by that clinic. So this is an example of where if you are able to get the prescription into their hands at the time of the visit, if you just eliminate the need for referrals and being seen by other clinics and just make it easier for people, that is a great way to engage people in PrEP use. Okay, and as far as PrEP and pregnancy and breastfeeding, it's important to note that women who are pregnant do seem to be at increased risk of HIV acquisition. Many people are concerned about the safety of PrEP in pregnancies and the effect on fertility, and that's noted to be a barrier for many cisgender women. It's really important to note that FTC-TDF has been studied very widely in persons with HIV, including pregnant women. So we have a wealth of data about the safety of these drugs in pregnancies. So it is not teratogenic, and we have very good confidence to say that based on our large antiretroviral pregnancy registry. The data from lactation studies in women with HIV suggests that there's limited drug exposure to the infants. And TDF-based PrEP has not been associated with differences in pregnancy or perinatal outcomes in several large studies. And so that's the daily recommended PrEP regimen of prescribing PrEP in pregnancy and breastfeeding. It's important to know that long-acting cabotegravir, we have far less data. There is some data. I don't think there's been any concerns raised to date, but we can't comment on the safety with the same degree of confidence that we can with FTC-TDF. Okay, so it's good to think about what strategies have been used to increase PrEP uptake or to support PrEP adherence for cisgender women in your area. I think this group is really understudied in the US and has not really been a major focus for PrEP outreach.
Thank you very much to Dr. Wilkin, and thank you to our listeners for joining in. As a reminder, to view the full Contemporary HIV Treatment and Prevention 2022 program on the Clinical Care Options website, and to access the slide set, click on the links in the show notes for this episode. Please be sure to check back regularly for more episodes on important infectious disease topics. Thank you and have a great day.